Good morning and good afternoon to those of you on the East Coast. Welcome to what promises to be an insightful and unscripted, I may add, discussion on one of the hottest topics of US healthcare today, the evolution of telemedicine as a result or as impacted by the COVID pandemic. And how do we look beyond the pandemic and predict how telemedicine will continue to evolve? This morning, you have already got a lot of good answers to a lot of good questions. And this live discussion will continue to react or continue the conversation from the sessions earlier today. My name is Magda Rusinowski. I'm a Vice President at the Business Group on Health, an organization that represents large self-insured employers. I have the pleasure of moderating today's discussion with the panelists that each represent a unique industry vantage point. So instead of me introducing them, I'm going to ask each one of you to briefly introduce yourself and the role you play in the healthcare ecosystem and whose perspective are you best positioned to represent based on your work for the purposes of today's discussion. Steve?
Hi everyone, Steve Blumenfield from Willis Towers Watson. Thanks so much for having me here today, everybody, and thanks, Magda. I'm Head of Strategy and Innovation for our Health and Benefits Group in North America, and I'm here to represent, hopefully, employers of all types, as well as the consultant point of view, so somewhat similar to your experience as well, Magda.
Bill?
Hi, I'm Bill Evans, and I wear noise-canceling headphones because I have too many kids in the background, so hopefully they do their job today. And I represent Rock Health in the point of view of an investor in early-stage digital health companies, one of which is Virta Health.
Sami?
Oh, thanks, Magda. So this is Sami Inkinen, CEO and co-founder of Virta Health, and a proud portfolio company of Rock Health as well. So we are a telemedicine company. So we have effectively a virtual diabetes clinic with individualized treatments to reverse type 2 diabetes, not just manage type 2 diabetes. And I guess, given that, the perspective that I can bring is we basically marry providers and care delivery with technology. So hopefully I can bring the perspective of providers as well as technology and how to use technology to transform care delivery.
We'll do our best to allow you to do so during this conversation. Dan?
Hey, good afternoon. Dan Schellenberger. I'm a partner with Oliver Wyman's Health and Life Sciences practice, and I lead our provider practice, and I'll represent more of the incumbent provider perspective, Sami, in contrast to perhaps yours.
That's a tough role you have, then. All right, let's get it started. As you have seen in the session description, COVID-19 has shown how quickly we can advance and mobilize medical care when we have the urgent need, when we have to, and when we have an urgent need to do so. And everybody seems to agree, at least everybody we talk to, that there's really no going back to the way we were. But looking at where we are now, have we taken the full advantage of the moment so far? And are we today, still in the midst of the pandemic, using telemedicine to its full advantage? Steve, I'll start with you.
Using telemedicine to its full advantage, well, that's, I don't know how high that goes, so I would say no. That's the safe bet on the, I guess, over-under on that one. But so much more can be done. But what happened with COVID-19 after we all got our footing, at least from my perspective, is that it created a lot of trial. A lot of, so many people who were reticent to try telemedicine of any sort had the reason now and almost the obligation to try it, because folks were frankly more afraid to go out of their homes or to a doctor's office or a hospital or emergency room than they were to try telemedicine. So you got an enormous amount of trial. Now, some of that trial will stick. Some people had a good experience. Some people, may go back to their old ways. So I would not want to extrapolate that rise will continue in the same way, but it created a lot of trial. And relatedly, but not just because of COVID-19, the market was already seeing telemedicine become this thing called virtual care. And whereas telemedicine tended to be associated with more primary care, even though it was more than that, even at that time, what we've seen evolve over time is this layer of primary care and a layer of specialty care. Basically, how do you treat your chronic condition management folks, or folks who need some kind of specialty encounter, and what's the optimal way of doing that? We like to think about virtual care, telemedicine as just a way of delivering whatever we want to get delivered. When I think about ordering a pizza, I can go to a store. I don't have to go to the store that was in my network. I can order it, right? I can send a text. I can do lots of things to get that pizza. Now, I'm not saying that medicine is pizza at all, but I am saying there are a lot of ways that we can do things on the consumer's terms. And that, to me, was the big aha moment that I think providers and employers saw. Wow, maybe this can work. And I'm hopeful that there's a lot more coming.
Thank you, Sammy. Steve has touched a little bit on the telemedicine, the evolution from telemedicine to virtual care concept. I'm wondering if you would like to add on this from the chronic condition perspective and your vantage point.
Yeah, well, I'm sure nobody wanted COVID-19 or this type of pandemic to happen, for sure. Now, the positive thing for us at Verta has been that the two key words that are sort of foundation of what we do is, one, fully virtual care delivery, and then two, improving type 2 diabetes outcomes. So in most cases, improving so much that we can reverse type 2 diabetes. It's this is the perfect moment for what we were built for. And just to be clear, we certainly did not hope COVID-19 to happen, but in many ways, the demand for what we deliver, both the outcomes and how we do it, has exploded in a positive way, unsurprisingly. So I guess the perspective that I'd bring is that while practically every provider is now a telemedicine provider, and like Steve said, ordering your pizza over the phone or calling your doctor over the phone is just a means of communicating. This replicating the episodic care delivery, calling your doctor, or calling your doctor once a quarter, or once a month, or once a year, it is helpful, obviously, that you don't have to drive to your doctor's office, which you don't want, or walk. You don't want to do that during the COVID-19. But when it relates to chronic disease care, that's kind of like replicating in the digital world what did not work in the past. So episodic care, whether it's in person or over the phone or over an app or computer, or quote unquote telemedicine, isn't really helpful for a chronic disease patients where you deal with the disease 24/7. And so I guess the one thing that I'd like to highlight is the way we deliver care, and I think most providers will deliver care for chronic disease patients in the future, is what we call continuous remote care. And to make it very simple, we interface with our patients 2 to 3 times, not per year, not per quarter, not per month, but per day. And that's enabled by technology. So what I'm hopeful and optimistic about is that technology will allow whole new ways of delivering care that's specifically tailored for certain conditions, such as for chronic disease. And these kinds of new models will then enable us to deliver a whole different level of outcomes, which, again, I mentioned a couple of times that type 2 diabetes can be reversed. It would not be possible with episodic care, in person or virtual, if it happens a couple of times a year.
I'll just jump in really quickly there to build on something, Sami, you were saying. The way we think about it comprehensively in the ecosystem, and Sami didn't set it up this way, but I've heard it spoken of as an or and not an and. There is both transactional level telemedical support that is needed and solution oriented telemedical support needed. And we distinguish, a company like Doctor on Demand in our portfolio, which is doing phenomenal work, growing very rapidly, organically right now, as being transactional and volume-based, which is not to say low value, but extraordinary value in the care paradigm that it's delivering in. And then really highly integrated solutions like Virta and others. And sort of we see those as being distinct value chains and distinct roles in the health economy.
And Bill, I'll play off that, Magda, and we'll keep rolling. Bill, I think you're exactly right. I think that COVID created a period in which people would try, Steve, as you said, but now there's an opportunity to convert trial into a much more longitudinal relationship. And I think that's where, there's going to be a land grab, quite frankly, or a period of time anyway, when we see which and how of those solutions can actually bring long-term value. It's interesting from the more institutional provider side, they all rushed. Those who didn't have telehealth programs stood them up quickly. Those who did saw them go from literally 50 visits to 4,000 visits a day. I mean, you've seen all the statistics; they're all true. But I think, Bill, to your point, it was hugely transactional. It was to unclog what was suddenly a clogged system, right? It was a means by which they could start to render care. Now, you play it forward, and most systems are starting to recover. They're seeing signs of improvement in their business, but they've still got massive holes in their balance sheets, right? They lost 2 months effectively of very profitable business. And what I'm not seeing as much of, and there are systems who are playing offense, but I think many are either still stuck in recovery or even in a state of repair. They're not thinking about how to capitalize on what those models mean and what they ultimately foretell of what their business model needs to look like going forward.
Mm-hmm. And I think we have heard a lot that putting a phone in or a camera in front of the provider doesn't make them virtual provider. And while as a system we have all had a knee-jerk reaction to COVID and switched to what was fortunately readily available, which were some of the telemedicine platforms and telehealth virtual platforms. It didn't necessarily create providers that were ready to do it. So this is a little bit of a longer term play. And as soon as you're done swallowing your water, Dan, I want to come back to you and ask you what will take the traditional brick and mortar providers to really adapt to a model that's maybe more integrated. I think it was probably you or Blue Cross Blue Shield of North Carolina that mentioned in the earlier remarks today via a conference that rapid adoption of providers is necessary now. What might that look like?
Yeah, I think there are a couple of things. Of course, it starts with reimbursement, right? I mean, you can go back through conferences like this for the last 20 years, and we've all had telehealth available and ready to roll, but it hasn't rolled. And why not? Well, there was no reimbursement, and COVID, of course, changed that. So first and foremost, if you're a provider, you're sitting there worried about how I'm going to get paid. And the irony, I'm in a lot of payer and provider conversations, and you hear payers say, well, gosh, that only took you 3 minutes. Well, I'm not going to pay you $150 at your usual office visit for that. I want to pay you, $4 for that, or some, ridiculously small number. So there's going to be this huge discussion and debate about what is value, right? And Sami, you should comment on this. Talking to people as many times as you do, per day or per week, the value of having that longitudinal relationship. But on the other side, for providers, and Magda, this is where they're just not able, quite frankly, to put the energy into rethinking their business models operationally and from a cost structure basis. They have to completely unwind from brick and mortar. They have to completely rethink staffing models and then tie all that to that reimbursement that I started with.
I mean, do they have to untie everything though, Dan? I mean, I would imagine that these models will exist in parallel.
Yeah.
And why? So why not do both? And I get it. I mean, this is a generational thing, yeah. But there's another challenge on the provider side, which is for self-insured employers, at least, they're still primarily buying through health plans, and the advantage that a solution has that can either be part of a virtual care model or in an independent carved out solution that's a center of excellence, let's say, that is applicable in all states, that can maybe work with the health plans and when the employer is It's available everywhere all the time. And when the providers do this on their own, it's wonderful for the members that are in that geography or that are affiliated with that provider. But until you have them everywhere, all over the place, virtually available, it's very difficult to replicate that. So I believe, at least, at least for some period of time, we're going to see both models exist in parallel. And maybe over time, it just becomes the way that everyone does medicine.
Mm-hmm. I'll jump in here. One thing that we think is highly investable is the mixed model, the deliberately mixed model, I should say. So there's an either and an or, and a full stack Virta is phenomenally tuned to deliver in a value oriented way on its mission. But in maternal care, where you absolutely have to have an in-person component, substance abuse disorder highly benefits from an in-person mixed model. We've invested into ULA and maternal care, substance abuse, a company called Marigold, which I'm really excited about. Most recently, we invested in pediatric behavioral and mental health in Brightline. And so we think that there are extraordinary opportunities to use technology, telemedical technology, communications technology broadly, with a brick and mortar, foot on the ground, to have a really high value and highly profitable business in this mixed mode. And that doesn't mean, the other thing that there's an and here, those models can work well with provider systems, to the extent that those systems are reconfiguring and of necessity right now, but in general, reconfiguring with that in mind. They themselves aren't necessarily going to build the mixed model of the future in every case. And they may or may not be willing to partner around these things too.
And I might add more and to Bill's comments. I mentioned earlier that this telemedicine revolution and separation of virtual or telemedicine doctors and traditional doctors reminds me of sort of the 1980s and 1990s software revolution, where there was a massive separation. Oh, here's a software company and here's a traditional company. And now even your local pizza shop or coffee shop is effectively a software company. At least they run software, CRM or Square, payment system. And I think the same will happen in medicine. This is sort of the and, where you will access some part of the service or the care with any provider through technological means remotely, whether that's a phone call or app or video visit. So I think we'll reasonably soon get away from this, there's the telemedicine doctors and then there's something traditional. I think it's going to be merged the way every company today is a software company. And then the other end that I wanted to briefly mention is this payment models. Having now been in healthcare, me and Verta for 6 years almost, there's so many existing guardrails that trying to just completely change everything overnight is never going to happen in healthcare. So I think both the outcomes-based or value-based and fee-for-service models will exist, and sometimes they actually come together. Like even in the case of Verta, we get paid for outcomes, but we still submit a claim which is the mechanism or vehicle for actual payment. So I don't think these models will completely transform overnight. So both will exist, but ultimately it should be outcomes, whether it's a lower cost, a better patient outcomes, the patient experience. And that's what technology and telemedicine should be driving. If it doesn't drive one of those three things, then it's just a shiny object.
Yeah, you answered my next question a little bit, because so we started talking about the mixed model of delivery and the mixed model of payment. The immediate solution has been for access, for convenience, for safety care, but ultimately what we're trying to drive and what we're trying to innovate and what we're trying to do in improving healthcare is improving quality and reducing cost. And I'm wondering, Sam, you got us started on this, but I'm wondering if the measurement of value in this new model of virtual or partially virtual, depending on situation, patient, and etc. If different measurements of value will emerge, and maybe no one better to get us started on that Bill, because as an investor and somebody who keeps the eyes on what's going on in innovation, measure, is it return on investment, is it VOI, or how are we thinking about driving value of virtual beyond of what it provides right now, which is an immediate solution solution to safety and access?
Yeah, I think so. I mean, that's a great question. I'll frame it this way. I think there's sort of three things in the road ahead that will deliver real challenges that have to be solved, but these are the value delivery opportunities. One, and in no particular order, one is the front door. So the more virtual we are, the more confusing this becomes for the consumer, whether that's the employer or a plan or the individual. Where do I go to get the care I need right now? How do I figure out which access point to start with? And there is no necessarily clear front door for the virtualized, unbundled world today, the way there is in the brick and mortar. The second I would mention is attribution, which is a narrower question about value in the sense that, and it's not just because we're an investor in Virta, but Virta is an extraordinarily clean story in terms of value and attribution. There is less expense and better outcome directly related to the cost of delivering the program, right? Fewer medications and better health is very clean and simple. But how do you, so its attribution is probably really, this is like a best case clean scenario. It gets very gray. So to the extent that we do better at that, we can create value and attribute value. And then the third I would say is coordination. Once you're in through the front door, once you've got the attribution problem, how do you coordinate among all those different providers? And that's another independent value stream in itself.
And I think coordination, both from the system perspective and also from how employers do different programs and build those different connections, is going to be another topic for another great conversation. I'm watching the clock and I'm watching questions coming in, and there's an interesting question that came from the audience. So let me pose that to you. How can purchasers, employers, and insurers specifically avoid health system self-interest to recover volume in the brick and mortar? So maybe starting with you, Dan, because you touched a little bit on it earlier, and then expanding to others.
Sure, that's a toughie. I don't know that I really want to answer it, quite frankly. The self-interest question, I think, is there. I think I guess what I would report from the front lines of having conversations with health systems is, I think they're seeing recovery to normal levels, but they're not seeing anything beyond that. So I wouldn't suggest that there's some kind of sawtooth curve that's happening where we're suddenly above capacity. So I'm not sure that that's a realistic expectation or concern. I think that to this conversation, you want people to be engaged in their care and thinking longer term about what their needs are. But outside of engaging your patients as they go into that continuum, I'm not sure what to tell you.
I have a thought on that. Since you posed that about employers and plan sponsors, health systems, and I'm looking at the same question here. To avoid self-interest, recover volume in brick and mortar, I don't think there's a need to avoid that. I think let brick and mortar systems do a fantastic job of making their value really, really clear, and let virtual do a terrific job making value really, really clear. And in the end, the consumer wins. And I think what we need is more innovation, better consumer focus, better marketing. The only way they'll be successful is if they do a better job at those things. And if that ends up in better care, better cost, better outcomes, better quality, just Sammy's points before, I think everybody wins. So there's no need. I don't think there's any need to hold it back.
And some of the trends we have seen, some of that volume was actually necessary. And as you said, Steve, we should be all rooting for some of that volume to be recovered, whether it's in vaccinations or screenings or earlier diagnosis for some of the really complex conditions. And I think the brick and mortar part of this question, the brick and mortar still has the limits. They cannot expand far beyond, but certainly the concern is unnecessary services coming back, and it's a very valid one. There is another question is, what advice do you have for digital point solution companies such as Virta and others to integrate with primary care models and forming network like the previous panelists have mentioned? That goes a little bit to this kind of building the whole new net of connections.
Yeah. I was waiting for Steve to jump in on that one, but I think, Steve, you partially already answered it, right? It's to some degree let the free market play out. In a perfect world, we'd allow patient flow to dictate some of those things. This is a common predicament, right? So many organizations that have run patient-centered medical home, initiatives for the last decade have seen good results, but they're kind of running out of steam. And now they're seeing these virtual solutions come in, and they're picking off patients. They're like, wait a minute, those are my profitable patients. It's like, well, either compete and win and create a better outcome, or change your business model and go do something else. So, as hard as that is to understand and think about in healthcare, that's kind of let the free market run. In the absence of some other intervention, from on high, seems likely to play out.
Now, there's a reason that companies like Verda that are outstanding at delivering against that clear mandate bill that you talked about are successful. It's because it works, right? I mean, all of the players are aligned in seeing value, and frankly, there are physicians involved, right? There are providers involved. It's just providers who are operating in a different construct. We're all going to get care ideally the way we want to, and the best care possible and the best in the ways we all want to access is the best answer, I think.
And to this point of need for integration, my experience and our experience over the last 6 years has been that there's been a lot of concerns that don't even exist. And what I mean by that is, one, we do the work with our continuous remote care platform and reversing type 2 diabetes in between the primary care physician visits, like literally. Secondly, we don't take money out of the pockets of primary care physicians. In fact, if they're compensated for clinical outcomes, we make money for them. And then this question like, well, you have to integrate. Sure, we communicate with the PCPs all the time, either directly integrated to their systems or faxes or emails. But in most cases, nobody even reads them. So we just happen to reverse type 2 diabetes in between the visits. And so we had a lot of people who were saying like, oh my God, how are you going to integrate? And then the reality is nobody really cares, despite our best efforts to be proactive and communicate to the PCPs. So sometimes, people come up with these obstacles and questions and concerns when the reality is there's reasonably little interaction between patients and their physicians when they aren't at the office.
And for some, personalization of care means that not for everybody, PCP has to be the quarterback of their care. For some living with one chronic condition, maybe the virtual solution is the quarterback of their care. But Bill, anything in the innovation space that you have seen when companies that were making those connections more effectively than others, or trends you're seeing in kind of weighing the importance of those connections as virtual solutions come to market?
Yeah, I think so. And I want to tie that to this point solutions question back to there's different issues that have to be addressed. Some that have been spoken to are whether and how your point solution integrates to other care delivery entities, be they remote or not. The other is just market and channel. And I think to the extent that there's an advantage to being paired up, partnered, or alongside, embedded in, and companies like Omada in Raquel's portfolio have done this very nicely, where they've paired a suite of offerings that for their population is comorbid around a number of things: mental behavioral health, MSK, diabetes prevention in their case. There's value because there's a channel that makes sense, that this population wants those things together. So I think that's sort of the trade-off decision. It's commercial and on the one hand, and it's clinical on the other. And you kind of have to have a really strong reason from a business model point of view to pursue something other than being a point solution and really focused, in which case you should.
Our audience is on fire. I saw 2 more questions come through, and the first one is fairly long, so maybe I'll try to my best to paraphrase. But it is about technology, and it's about the devices that some view as necessary to support adoption of telemedicine, such as those that measure symptoms or check biomarkers. So, do you think further development, technological development, is key for the growth and development of further development of telemedicine or new applications of telemedicine?
No.
Right.
I think we got a
Staying
lot of
right.
really good tech and business models, meaning commercial models, clinical models, meaning the practice of medicine, and insofar as it integrates those tools. Those are the major barriers right now. And don't get me wrong, we're going to invest, Rock Health, in really exciting new technologies. But if you're asking me the question about what is the rate limiter in the system, it's the other things.
Yeah, agreed.
Agreed.
Great. And to some cases, maybe it's connecting them better or the data, but it sounds like we have enough room to grow with what we have right now.
And even I would add there that although I'm a technologist and I love the latest and the greatest tech, we've been so focused on features and tech. And what is it that matters in healthcare? It is outcomes. It is outcomes, not the features. And outcomes, you can think of it broadly: clinical outcomes, better patient experience, lower cost. But I do think we have enough features. What we all collectively have to really focus on is how.
I think Sam, go ahead, Dan.
No, I think we all get the point, right? It's and we've said this before. We have plenty of innovation. We just have to get it out there and get it into the process so that people can actually experience it. So, fully agree.
Yes, the pipeline has been rich, and there's still a lot of room for adoption of more of what we already have. There's a question about Medicaid population coming in. So brace yourself. What are the biggest barriers to driving adoption to the digital front door for Medicaid population and also the elderly and frail? How do we catalyze adoption of digital first care delivery in these populations? So elderly being less willing to adopt maybe, or is this a deeper question, and what are your observations there?
Yeah. I'll jump in first as someone who works across populations. So first off, I think these are often intuitions that are often debunked with data, right? So there are often times when you'll say, oh, the seniors don't want to use anything with technology, and not true. So you have to be very careful with how we think about segmentation. The other thing I would offer, and I think this is early days still, but there's a lot greater, I think, focus, and rightly so, on racial equity in healthcare and on access overall, with respect to people's socioeconomic status. And so, Magda, I don't think that's an answer to the question as much as it is. I do think there are a lot of incumbents, the insurance companies, who care for these populations, as well as the providers who often have missions oriented towards, poor and vulnerable populations that is very much focused on this. Last comment, yeah, there's a digital divide out there. So my root answer, I think, to the question would be, access to Wi-Fi and the actual bandwidth that people need to be able to sustain these solutions.
So I don't have a lot of insight to add to Dan's comment because I don't focus in that space as much. But I will say, when it comes to hard to reach populations, that the answer is to find every way possible to reach that population, and maybe getting creative about the ways to reach people around whatever their social determinants of health are. People, we see this with people with low incomes. We see this with people with poor care and without access to care. You just have to find ways to do it. And I can't give advice to the Medicaid population, but there's other innovations out there, whether it's knocking on doors, whether it's different modalities of care, whether it's experiments in retail care for chronic condition management. So not every solution is going to be able to bridge the divide for every person. But I agree, if we could do a lot by making some of the technologies more available to those most in need.
Yeah, I'll chime in here and just speak to the data that's necessary here. So Rock Health, over the last 6 years now, has done it's essentially a study that surveys a representative sample of the U.S. Adult population 18 and over, and asks them about adoption of digital health tools, including telemedical tools. And we've published on this with Stanford Center for Digital Health, and are going to do some really interesting stuff in the next few weeks, so stay tuned. The comment that Dan made earlier is that intuition is often wrong, And what I think is really interesting is to look into segments and ask questions about when, for example, a segment is generally a low adopting segment. And let's say that, you know, aging adults in certain use cases are lower adopters, but there are subgroups that are higher adopters. And so I'll give you an example, and this is where I think the answer lies, is just to interrogate these. But aging adults who are told by their physician first to please use this solution have adoption rates that mirror and even exceed other high adopter segments. And so I think the lessons here are, you know, not so much, oh, which segments aren't adopting and which ones are. It's what are the counter moves and where are the positive deviations that we should follow as an industry so that we can drive adoption. Because adoption isn't a phenomenon like the weather. It's something that we actually change over time with brilliant innovators, you know, like the folks in our portfolio.
So I'll add two things quickly. One, echoing Bill and Dan here, just to give you a data point. Virta outcomes among folks 65 and older are better than on average across our entire population. When I talk about outcomes, type 2 diabetes reversal rate, retention, medication elimination, so forth, which was counterintuitive for me. This is one thing. And the second thing is, particularly for those who are coming from the tech world and want to enter healthcare and build something, it is very, very important to realize that what you can do in a direct-to-consumer world, which is to say, let's create something really cool, the next Instagram, and you need to have the latest iPhone to use this. It's a viable model in the direct-to-consumer world, but it does not work when you're treating populations, because then you have to find the lowest common denominator or be sort of channel agnostic. Sometimes all you have is text message to work with. So it's just a very different mindset when you have to treat a population versus a beachhead to the latest iPhone carrying user base. That's a very, very important thing to just keep in mind if somebody's coming to healthcare from the traditional consumer tech.
I think it's a perfect conclusion to this conversation. We have started this with, I think Steve said that COVID has forced patients to try new things out, or maybe it was Dan, I don't remember anymore. But I think this pandemic, more than anything, has shown that we are all adaptable. I mean, look at us now. This was a perfect panel discussion, and I don't think we have ever met in person at all. So all kinds of people have been willing to adapt when needed during the pandemic. And so will the seniors, and so will everybody else, to take advantage of what's available to them. And it's really, as long as those solutions and the platforms can demonstrate value and can offer the experience that people are seeking. And I have seen in one of the meetings I ran recently some of the very encouraging data about patient satisfaction over the last 3 months. So with that, an optimistic maybe view of the future, that we're on the way not only to recovery in healthcare, but also on the way to better healthcare of the future with the help of telemedicine. I wanted to thank you for this wonderful discussion. I know we're 5 minutes past the time, but I was allowed to do that, so I took advantage. And thank you to the audience for excellent questions that kept coming in, that saved me from having to make them up on the fly. So I really appreciate that. And goodbye, everyone.
Bye, thanks.
Thank you.
Bye-bye.